So this is the patient we have, 4 patients, right? And this is aware of several clients in the emergency department. You have 4 patients, 10 years old, with epistaxis for 5 minutes, right? Nosebleed, 5 minutes. 12 years old with knee pain, 8 out of 10, and fatigue. 17 years old with left flank pain, nausea, and small emesis. 12 years old with scrotal pain, swelling with elevation of the left testicles. You have to be sharp. Which situation give you a pause? Go for the buzzwords. There's all of them as buzzwords. You can figure out. You don't need a bunch of information to make diagnosis for what I've given you. So which of these patients do you think is troublesome? Look, I try not to give you too much words, and I try to let you focus on some big words that your board will put it there, and it give you an idea, like I call it. You pop it like a candy. If you know this information is enough, you don't need a bunch of information. Problem. Based on the information given, you can see D is more serious. It's more serious. So prioritization wise, D is the patient you have to see. Because of the way I said the question, I'm not going to give away the diagnosis. At the end, you figure out the diagnosis. But based on the individual symptoms, and option D is more serious based on what I'm seeing. The physical finding, in addition to the complaint, scrotal pain, swelling with the elevation of the testicles, is a bad problem. Left flank pain, nausea, and small emesis is also a bad problem. Knee pain, 8 out of 10, and fatigue is also a bad problem. Epistaxis for 5 minutes is still a bad problem. But D problem is the worst. So now I've given it to you. This is the history of client D. Does that give you enough information? Does that make you, if you selected D, does it give you an idea that, oh yeah, you were right, right? The client reports sudden onset of severe scrotal pain, right? That's a buzzword. But that pain is not enough. Some nausea associated with vomit ×2, that is ischemia, before coming to the emergency room. He has frequent urination. It's not UTI. It's febrile 200, tachycardic, blood pressure is fine. It's alert oriented, his lung is clear, S1, S2 is present. On the left side, in his groin area, you can feel a mass there. There's a mass, groin mass there. And the left testicles is higher than the right, right? And it's located in the left groin. It's very tender. It's moderate tenderness, right? What do you think is this problem? And what would you do? I've given you enough information. Initially, I just give you the buzzword, right? Scrotal pain and the location of the pain. But now I've given you everything that you deserve. So all this information has given you client D. This is his problem, right? If you know what he has, then you should be able to tell me which of the following intervention are indicated. Scrotal ultrasound, prepare for surgery, insert NG tube, insert Foley catheter, get a CT scan of the abdomen. If you know only one, you pick it. If you know only two, you pick it. So I can tell you this patient needs surgery, right? But sometimes this is not hard to get. You can get an ultrasound quickly and at bedside, and you take the patient to surgery. Confirmation, that's all. So scrotal ultrasound is indicated by the patient who needs surgery. It does not need NG tube. The vomit is from pain. So you have nausea and you vomit. It's like appendicitis. The pain from the inflammation make you become nauseated and you vomit. So this does not require NG tube. The frequent urination is due to the torsion. We don't need Foley catheter. Our physical exams and ultrasound is enough. We don't need CT scan of the abdomen. So those two are what is indicated for these patients, and that's okay for us. Okay. The next, perform further assessment on client A. So this is client A. So this is, I will show you the initial client. This is what I gave you. 10 years old with epistaxis for 5 minutes, right? It was not our priority, but the nurse did a further evaluation on this patient. So what did he find? We did a further evaluation on that patient, and that's what we got. Now, this is the parent statement. My baby has been having fever, fatigue, bleeding, joint pain for 3 months. Okay. 2 to 3 times of what? Sore throat and runny nose each month. So every month he's going to get sore throat 2 to 3 times. There is easy fatigability. That means he get easily fatigued when he walks around, right? My child does not enjoy soccer game anymore due to what? Frequent fall and joint. These are all buzzwords. It should be telling you something by now. Is febrile, tachycardic, right? Respiratory rate is a little bit up, but it's not that much. It's alert oriented. His mucous memory is dry. His nosebleed is no more. There's no active bleeding, but you saw some dry blood in his nose. His lung is clear. His S1, S2 present. He has no murmur. His abdomen is soft. His spleen and liver is enlarged. He has bruises with different stages of healing. Put it together. Connect the dot. And try to connect the dot, and I'll help you. Okay, this is a buzzword. Okay, spleen and liver is also a buzzword, right? There's no nosebleed, but it was having nosebleed before, so it's a buzzword, right? It's tachycardic and a little bit febrile is also a buzzword. And the first one is a bunch of buzzwords: fever, fatigue, bleeding, joint pain. This is also a buzzword. 2 to 3 times of what? Sore throat every month. That's a lot to have that kind of problem. Can you figure it out? And he's been having joint pain. Can you figure out what is wrong with this patient? I think I've given you enough to figure out what is the diagnosis. I'm not going to give you the diagnosis. I'll give it to you at the end. But what is the diagnosis for this patient? Expect your board to do that to you. They will not let you figure out what is the diagnosis. You can walk through the cases without anything. That is what I'm hearing. That they can give you the case without asking you for diagnosis. But you have to know at the back of your head what is going on. So this is the problem. What do you think we should do for this patient? So the answers may give you a clue. So we want to get a complete blood count. We want to get a bone marrow biopsy and aspiration. We want to make the patient MPO. We want to use cold compression on the nose, and we want to hold pressure for 15 minutes. So what do you want to do? You want to get a CBC. I think we should get a CBC. You want to, I see two answers there. I want to comment on it. Osteoporosis, I will have given you signs and symptoms related to osteoporosis. I will tell you the individual height will change. They will be weak, but they will have frequent fracture. And the age of the patient is not consistent with that. Patient is 10 years old. It can be osteoporosis. If it's osteoporosis, I will tell you it's a female also. Hemophilia, it may be, but hemophilia does not have recurrent infection. So those are the things you'll be thinking about. It can be hemophilia because you don't have recurrent infection. You can have joint tenderness, joint pain, and you can have nosebleed, but I'll tell you they have joint pain, right? So that cannot be, by day two, they don't have recurrent infection. I think bone marrow biopsy is a good thing for this patient, right? Patient has bruising, patient has recurrent infection, and patient has fatigue. Those are your clue, right? Those are your clue. It can be sickle cell because I told you it's not acute onset. It wasn't an acute onset. So that's also a clue for you if you're picking that. That may, and then we should make this patient NPO until we figure out what is going on. For nosebleed, yes, specifically nosebleed, right? When you're bleeding, cold compression is good. And the key is you have to hold pressure for 15 minutes. Continuous pressure is the treatment of choice for nosebleed. 15 minutes. And I know we all get told when you have nosebleed, put your head back. Your head should be tilted back. That's always wrong. You shouldn't do that. You should rather lean forward and the blood would drip. You don't want to tilt your head backward so that the blood go to the back of your throat. No, it can cause problem. So when you have nosebleed, lean forward, let the blood drip, hold pressure for 15 good minutes. I mean, continuous pressure. You hold it in for 15 minutes without letting go. So we should do that for this patient. So that's all we have to do. Once again, that's the patient. Mommy said fatigue, fever, bleeding, joint pain for 3 months, recurrent sore throat, runny nose every month, like 2 to 3 times. Patient cannot play soccer anymore because he's falling, right? His spleen is a little bit bigger. He has bruising from different stages of wound healing. Okay, I don't know what else I will give you. Okay, so that's enough I've given you. Next one. Which of the following intervention the nurse should include in the plan of care? Okay, so now for the same patient, client A, right? So this is the client. Now we did a bone marrow biopsy. This is what we get. Rapid growing and overcrowding lymphoblastic leukemia. Does that make sense to you now? This is what we find. You said you want bone marrow biopsy. I gave you. You said you want a white CBC. I have RBC, immature cells, right? Platelet, they also immatured. White blood cell, also immature cells. PT, PTT, INR also was normal. Therefore, it has nothing to do with coagulation, right? It's all related to bone marrow, and the red blood cell is decreased. Immature means you don't have regular red blood cell. So immature, platelet is also immature, white cells is also immature. So your red cells is decreased, your platelet is decreased, and your white cells is decreased. Remember, sometimes they don't tell you decrease, they will give you immature, which is the same. That means you don't have enough um, um, regular cells. So you have a bunch of immature cells all over. That means they're trying to reproduce very fast. Okay? It cannot be Kawasaki either because Kawasaki, the key for Kawasaki, if you watch videos that tell you T creams, I will have told you that this patient will have fever for 5 days, will have conjunctivitis, will have rash, which is erythema, mucositis, right, and adenopathy. So this patient does not have Kawasaki based on the lab work. And we don't need bone marrow biopsy for Kawasaki patient. So patient, what do we have? We have lymphocytic leukemia cells, immature red blood cell, platelet, white cells, and PTT, INI is normal. Based on this, what do you think we should do for this patient? The diagnosis is here. Even though I've not said it, it's right here, right? This is your diagnosis with all these features, right? And so, what do you think? We should prepare for chemotherapy. We should prepare for chemotherapy, right? The patient is sick now. He's sick. He has lymphocytic leukemia. He should get a private room, right? I know you agree with me because now we have a sick patient. The nurse should wash their hands really well. Otherwise, we get into trouble, right? And if you have to transfuse them, you should make sure there's no, you take all leukocytes from it. So we call it transfused leukocyte reduced irradiated blood product. So these black products will be leukocyte reduced and irradiated from any chemicals that will trigger infection, right? So this is good. We should disinfect all equipment before you use. And then F, who who think that's the correct answer or who think is the wrong answer? Who is going to pick F, droplet precaution? Droplet precaution. Is this the droplet precaution? What kind of precaution this patient need? Standard precaution. Excellent. So is a leukemia patient. There's no infectious problem. You just have to provide standard precaution and then wash your hands. So these are what we do. We get a chemotherapy, we place this patient in private room, we wash our hand completely, we transfuse them, blood product that are leukocyte reduced, and then we clean all equipment. This patient does not need droplet precaution based on the condition. So this is a wrong, so don't pick it. And next, review the clinical data. Anybody have any questions? So standard precaution for that. And then review the clinical data below after further assessment of client C. So this is client C when he came in. 17 years old with left flank pain, nausea, small emesis. So that's what he came in with, right? 17 years old. Now we did more assessment. I've given you more information now. The client reports what? Left flank pain, okay? Nausea, vomiting for 2 days. Those are buzzwords. Pay attention. Left flank pain. That's what I said. I did not say abdominal pain. Left flank pain. I said nausea. And I said vomit for 2 days. It's LMP, last menstrual period. I'm trying to get you away of thinking something else. Is right? Last menstrual period is 2 weeks ago. Okay. Patient is feverish and some chills, right? There's no vaginal bleeding. No vaginal bleeding. She's 17, but there's no vaginal bleeding. There's burning on urination. Is that getting to you? Are you trying to figure out? There's urine urgency and urine frequency. The pain does not radiate to the groin. So the left flank pain stay there. Okay. It does not radiate to the groin. It's febrile, tachy, so rented, lungs, abdomen, everything is fine. And moderate what? Costovertebral angle tenderness, CVA tenderness. And there is no normal vaginal exams. There is normal vaginal exams, moderate costovertebral angle tenderness, CVA tenderness, abdominal exams is fine, lung is okay, alert, I have fever, I'm tachycardic, I have what? Burning on urination, urgency and frequency. I'm not bleeding. Do you want to get urine culture? Do you want to get beta ACG? Do you want to get transvaginal ultrasound? Do you want to give the patient antibiotic? Do you want to prescribe antipyretic? And do you want to give the patient IV fluid? I can tell you we need urine analysis, urine culture. What else you want to do? What else? What else you want to do? She's in the hospital with the left flank pain, right? Any patient that coming, female patient that coming, young, who is sexually active, need a pregnancy test, especially if they have abdominal pain, beta ACG to do that. All right. We may need an antibiotic. We may need a patient is febrile, right? So we may have to give them something to help the fever. And then we need some fluid. Who was client C? This was it. The same patient, right? Left flank pain, nausea. And so we did whatever we want to get. This is what we got. White cells, 13,000, right? Beta ACG is negative, right? So she's not pregnant. You did a urine analysis. There's bacteria there. There's blood. There's leukocyte esterase. There's nitrates. So all of it is positive. That means the urine is dirty, right? So we have a dirty urine. If we have a dirty urine, that means something is not right. Based on that, okay, I've given you these options. We're already giving you the answer for D. I told you it's not a topic. Use that. So what do you think? Does the patient have cystitis? Does the patient have nephrolithiasis? Does the patient have pyelonephritis? Does the patient have ectopic pregnancy? Right? When you see it, I'll draw. So your bladder is here like that. There's two types. There's pyelo, nephro, and cystitis. They're all going to have UA that is positive. Fine. Sometimes burning, sometimes blood in the urine. But cystitis is here. Cystitis is here. Patient is going to have pain, suprapubic pain. There is no suprapubic pain in this question. So don't pick A. I did not tell you there's suprapubic pain. At the same time, patient has chills. The chills rule out, and the nausea and the vomit a little bit. These rule out cystitis. People who have just UTI, cystitis, bladder infection does not cause that kind of symptoms. Nephrolithiasis is kidney stone. The pain go to the groin, irradiate to the flank, and go to the groin. Once again, radiate to the flank and go to the groin. And it's usually colic. Your board has to give you to make the exams fair. Those are what I call buzzwords. When I say buzzwords, those are the things. They cannot set an exams without giving you a nephrolithiasis question and not telling you pain radiate from the flank to the groin. Okay, and it's colicky in nature. That and it's acute onset. They have to use that word to make the exams fair. So they cannot hide that. I never said that. Therefore, and we know this patient is not pregnant, so it's pyelo. Pyelo, fever, nausea, signs of polyuria, and a CVA tenderness. The presence of CVA tenderness, costovertebral angle tenderness, is consistent with pyelonephritis. So this patient has this. And fatigue, we've not talked about him. Now let's go and look at B. Who is B? 12-year-old, knee pain and fatigue. So this was B. Now, client report acute onset of what? Upper back and knee pain after hiking with family for 3 hours. You get a clue now? You know what the patient is suffering from? Feels dizzy and tired, right? Similar symptoms with change in altitude. Whenever there's a change in altitude, you get the same symptoms. Or when you have UR symptoms or prolonged exposure to heat or extreme cold. Does that give you a clue? Tachycardic, right? It's alert oriented. Abdomen is soft. There's no ecchymosis, okay? There's no bleeding anywhere. There's multiple joint tenderness. Hemoglobin is 9. Hematocrit is 28. Does that tell you something? Anemia. Then we have leukocyte count, 6%. It's supposed to be 2%. Can you figure out what is wrong with this patient? I've given you enough information to figure it out. Acute onset, upper back pain, knee pain. When you go on hiking for 3 hours, you get the same thing when it's cold, when it's hot, when you change altitude, or when you have upper respiratory infection. Okay, you have heart rate of 105, right? You have multiple joint tenderness. Your hemoglobin is low. Your hematocrit is low, and you have a bunch of leukocyte counts in your reticulocyte count That means cells are dying. What do you think? I know you got it. But these are the way to do next generation NCLEX. There's no other way I can explain it to you, but this is the way. You have to look at a case and go for the buzzwords. There's a bunch of things there, but there's also buzzwords that should be ringing in your ear. This lab work give the answer away. The joint pain give the answer away. The no ecchymosis rule out other problem. Patient is tachycardic, right? It's a clue. Similar symptoms when it's going to altitude, infection, exposure, cold is also okay. And then I have acute onset of back pain after I went out for hiking for 3 hours. So what do you think the patient is suffering from? And if you know what this patient is suffering from, what will be your plan? The symptoms of sickle cell patient. So this is a sickle cell patient based on the leukocyte count, based on the signs and symptoms, presentation, tachycardic, and multiple joint. So we have sickle cell patient. If you know this is a sickle cell patient, what are you going to do? Nothing by mouth, private room, cold compression to painful areas, patient control anesthesia, sequential compression device, loose fitting clothes, supplementary oxygen, 5% albumin, hydroxyurea. The question say which one you should question. So something the patient not supposed to be prescribed. So you're going to question it. So which one? I can tell you, sickle cell, you should hydrate them. So you should not make them NPO. So we got to question that. Okay. Private room is good because they get sick easily, so their spleen doesn't work, so they're more likely to get infection. So private room is a good thing. You should not apply cold compression on a sickle cell patient. You want blood flow. So anything that is going to cause constrictive blood flow is your answer. So cold compression is a bad. We should question that order. A sickle cell patient should get a lot of pain medication. They should not, and then PCA, patient control anesthesia morphine. Yeah, PCA morphine is good for them and they can use it. You should not place SCDs on them. SCDs is going to cause compression. So we got to question it. What about F2AI? So giving your answers for F2I. If we're not going to place a sequential compression device which is constricting, then we should give them a what? Loose fitting clothes so that it doesn't constrict them, right? They will need oxygen. Oxygen is good. So oxygen hydration is good for sickle cell patient, right? If you have to resuscitate somebody, 5% albumin is not used for resuscitation. Once again, if you have to resuscitate, every time somebody you're taking the test and you need to give a patient fluid, always choose lactate ringer or normal saline, 29.9%. Unless it's a brain patient, right? Unless it's a brain patient, they get 3% or 5%, right? Those are the fluid, or unless it's somebody with cirrhosis. If you have cirrhosis, you get albumin. So these are the only difference. But every time you got to give a patient fluid, just give them lactate ringer or normal saline. So isotonic fluid solution. So 5% albumin, we got to question it. And for sickle cell, hydroxyurea is used as a maintenance to increase fetal hemoglobin, right? But this is used for chronic condition. So it's using as a chronic maintenance, not acute. So in acute situation, it does not work. So we don't have to worry about it. So we got to question this And we got to question this too. We already talked about it. So this is just for you to make a diagnosis. So client A, match the diagnosis for each of them. So client A, this is client A, right? 10-year-old epistaxis for 5 minutes. And we know A is a leukemia patient, right? Client B, I already told you, is a sickle cell. So it's a vaso-occlusive disease. And client C, we talk about it, is a pyelonephritis. And then this is testicular torsion. So that's what we got. Okay, guys, we're almost done. Now, since you know what is the problem, then you can be able to figure out, right? Figure out what match the major complication the nurse should be concerned about for each client. You know what A is, you know what B is, you know what C is, and you know what D is. A is what? Leukemia. B is sickle cell. C is pyelonephritis. And D is torsion. So now you got to match the major complication. What do you think? Myelosuppression. Excellent. How about B? B is vaso-occlusive, ischemic organ damage, stroke, or sepsis. So B is stroke. Major problem is stroke. They can get stroke. Stroke is ischemia. For stroke, it's common in a patient with sickle cell. So you got to be careful with them. The major complication go with the torsion and the pyelonephritis. In terms of ischemia damage, you go with the torsion because the torsion is a twisting of the testicle. Blood flow is going to be cut off, and then the testicles will lose his blood supply and he die. Sepsis is from pyelonephritis, and then stroke is sickle cell line. So this is client A, right? Fever, fatigue, bleeding, joint pain, all these things, and we already know this patient has leukemia, right? We saw the blood work consistent with that. Patient is about to go home. We know patient has ALR. There's one thing you want to do for this patient that you should never forget. It's called neutropenic what? Precaution. Because the patient is going to go home. So neutropenic precaution. These are the things you include in neutropenic precaution. So which of those should you include then? Giving the answer away. I said which teaching you should include, but at the back of your mind, you should know, oh, it's neutropenic precaution. You should avoid large crowds. That's what most people say, right? You should avoid sick contact, right? And then you left with A, B, and D, right? They should avoid live vaccine, right? So they should not get nasal flu vaccine is what? It's a live vaccine. So that's a trap. So they should not get D. D is wrong answer, right? You should never put anything in their rectum. Anybody who have leukemia, lymphoma, don't put anything in their rectum. So enema or suppository is not a good choice. Okay? And then they should avoid fresh vegetables, raw. That's the last question. Taking care of all these three questions content, but which one of them should give you a pause? If you have to give a second, which one will you give it to? Or which one you should worry about? That is adapting class. I'm about to sign out quickly. But which one do you think is a problem? This is what we call B sharp. You have to worry about breathing problem. You have to worry about electrolyte problem. You have to worry about shock and sepsis. You have to worry about hypothermia. You have to worry about airway issue, neurologic, and pain, but not to be expected, right? This is classic way. Sickle cell patient. I expect the patient to have 8 out of 10 pain. She came in with 8 out of 10. 6 hours later, if she has that, it's okay. I'll figure it out. We'll help with that. This is unexpected. Hemoglobin of 8.5. She came in with 9. Well, I expect her to be anemic, right? I'm not going to cry over it. I'm being sharp. This is an unexpected finding. It's abnormal, but I'm being sharp. It does. Then this one, 27.5, she came in with 28. Well, I'm being sharp. People with sickle cell, their spleen is small. The spleen is infected. So spleen small is infected. It's ischemia. He died because of multiple ischemia. But if it get bigger, it means he's sequestrating a lot of what? Blood. Now it's enlarged. It's not supposed to be small, big. It's bigger than what it is expected. And I said, be sharp, not expected. This is an unexpected finding. Therefore, a large spleen, it means shock. They're going to hemorrhage and they will die. This is a priority. So C is your right answer. This is Adapt NCLEX. Thank you for watching.